Good morning everyone. Today we are going to discuss about diagnosis and the treatment. Diagnosis and case history. And coming to the definition of the diagnosis is defined as the examination of the physical state, evaluation of the mental makeup, and understanding the needs of each patient to ensure the predictable results. Let us go to the case history. First, we have to establish rapport. It means getting familiar with the patient to gain his trust or win his confidence. It includes the dentist's attitude and behavior, general introduction to the patient, observation of the patient, and we should observe the patient's motor skill, facial features, attitude, and adaptive response. The general introduction of the patient includes the chief complaint, which should be written in the patient's own words, and it is important to know if the patient has recently become edentulous and it has become edentulous condition is for a long time, or it is contemplating complete extraction and recently made edentulous extraction and subject to rapid changes and resorption of the ridge. And Housey has classified the attitude of the patient in 4 classification, like type 1 philosophical, type 2 exhausting, historical, and indifferent. What's the application of the Housey's classification? Dentists should learn to detect patients' attitudes and reaction during diagnostic appointments and modify their own attitude and reactions by which mutual confidence can be established. Dentists must have a sense of real concern for the health, comfort, and welfare of the patient to establish the mutual confidence. To the history, it includes social history, medical history, dental history, and the drug history. In social history, first comes the name. It brings the confidence and psychological security to the patient. Next comes the age. Young persons are more adaptable and facility for learning and coordination diminishes with age, and through 4th decade tissue heal rapidly, and beyond 5th decade it doesn't heal rapidly, and oral facial structure it might be less elastic and resilient. And coming to the sex, appearance is a higher priority for the women, and race it is a critical factor for the characterization of the dentures, and address is used for the further correspondence. And occupation, patient jobs and social standard plays role in aesthetic and other qualities in a denture. And patient's habit, it reveals patient consent about the dental health. Coming to the medical history, it determines any condition that affect procedure and outcome of the treatment. By being aware, the practitioner is ready in case of any medical emergencies arising during treatment. And transmissible diseases, suitable precautions can be made to decontaminate the operatory as well as to prevent its transfer. And dentist may be the first person to discuss Coming to the fullness of the lip is directly related to the support it gets from the mucosa or denture base and teeth in the back of it. Lip fullness should not be confused with the lip thickness, which involves the intrinsic structure of the lip. Coming to the lip mobility, it might be normal, reduced and paralyzed. Patients with minimal lip mobility show very little or anterior teeth. Some stroke victims may have paralysis of half of the lip, leading to unilateral mouth droop and facial asymmetry. Patients may be counseled regarding treatment limitation and dealing with such physical challenges. Coming to the health, lips should be examined for the cracking, fissuring and at the corners and ulceration, and this might be changes due to the vitamin B complex deficiencies. It might be due to Candida albicans and can be neoplastic condition. When proper lip support has been developed, these anatomical landmarks will exhibit a distinct normal appearance. Without proper support, there is noticeable deepening of the nasolabial and mesolabial sulci. There is also a loss of definition in the philtrum and a lowering or drooping of the corners of the mouth. Coming to the neuromuscular evaluation, poor neuromuscular coordination is difficult to adopt a new denture. Neuromuscular coordination may be classified as class 1 excellent, class 2 fair, class 3 poor. This is how we examine TMJ examination. If pain or difficulty is in the opening of the mouth, check for the tenderness, clicking or crepitus, and uncoordinated jerky movements indicate difficulty in the jaw relation. Coming to the intraoral examination, it includes soft tissue and hard tissue examination. Coming to the soft tissue examination, first is cheek. See the general contour of the cheek, filling buccal spaces, which needs the concave buccal contour and of the denture. And mucosa, it is mainly masticatory lining and specialized mucosa. Masticatory mucosa covers the hard palate, crest of the residual ridge, including the residual attached gingiva firmly adherent to the supporting bone, and lining mucosa covers the lips, vestibular spaces, alveolingual sulcus, soft palate, ventral surface of the tongue. And specialized covers the dorsal surface of the tongue, keratinized, and includes specialized papillae on the surface of the tongue. And Wright has classified the tongue position, class 1, class 2 and class 3. And class 1, where the tongue lies in the floor of the mouth, tip forward and slightly below the incisal edges of the mandibular anterior teeth. And class 2, tongue flattened and broadened, tip is in the normal position. And class 3, tongue retracted and depressed in the floor of the mouth with the tip curled upward, downward or assimilated into the body of the tongue. Coming to tongue size, according to the House, class 1, normal in size, development and function. Sufficient teeth present to maintain normal form and function. In class 2, teeth absent long enough to permit a change in the form and function of the tongue. And class 3, excessively large tongue, teeth absent for extended period of time. And coming to the floor of the mouth, if near the ridge crust at the rest or the magnitude of the movement is greater, retention and stability is poor. Coming to the frenal attachment, according to the House, class 1, it is high in the maxilla or low in the mandible with respect to the crest of ridge. Is located away from the crest of the ridge. And class 2, it is medium nearer to the crest of ridge. And class 3, freni encroaches on the crest of the ridge and may interfere with the denture sheath, and surgical correction of these frenal attachments may be required. Coming to the hard palate of the shape of the hard palate can be U-shaped, V-shaped and flat or shallow walled. U-shape most favorable and better retention and stability. V-shape not very favorable. It is has slight movements of the denture breaks the seal and loss of retention. And flat or shallow walled, reduced resistance to lateral and rotatory forces, usually accompanied by resorption. Come to the soft palate. It divided into class 1, class 2 and class 3. Class 1 shows horizontal curving downwards. Most favorable and more surface area are covered for retention and wider seal area. It is more than 5 mm of the movable tissue is available for postming. Coming to the class 2, palate turns downwards at about 45 degrees angle at the heart to the hard palate. It is 1 to 5 mm of movable tissues available for post-jamming and good retention is usually possible. And class 3, it turns downward sharply at 70 degrees angle, greater movement of soft palate during function and the narrower seal area, hence less favorable. Coming to the lateral throat form, it is bounded by anteriorly mylohyoid muscle, laterally by pear-shaped pad, posterolaterally by subconstrictor muscles, and medially by palatoglossal muscle, and medially by the tongue. And class 1, it is divided into class 1, class 2 and class 2 and class 3. Class 1, this forms indicates that anatomical structure will accommodate a fairly long and a wide flange, and thickness of the border usually 2 to 3 mm thick. But thicker border of 4 to 5 mm should be used for the better seal if the border is flat. Class 2 is about half as long as narrow as the class 1 and about twice as long of the class 3. And class C, this forms has minimum length and thickness. Border usually ends 2 to 3 mm below the mylohyoid ridge or sometimes just the ridge. Coming to the hard tissue examination, arch size, denture bearing area increases with the arch size and decreases with the retention. And is classified into class 1, class 2 and class 3. Class 1 large, it is ideal for retention and stability. Class 2 is average, is also good retention and stability. Class 3 is small, difficult to achieve good and retention and stability. And arch form is also plays an important role for the denture. Class 1 is square and favorable shape. Class 2 tapered, it has less retention and stability. Class 3 ovoid, comparatively less common. And ridge contour, which should be inspected and palpated, and this should be classified based on the contour as high ridge with flat crest and parallel side, flat ridge, knife edge ridge. According to classification of the maxillary ridge contour, like class 1 square or gently rounded, class 2 tapering or V shape, class 3 flat. And classification of the mandibular ridge contour, class 1 inverted U shape where the parallel was medium to tall ridge with broad ridge crest. Class 2 inverted U shape with short with flat crest, and class 3 unfavorable condition. And coming to the cross section of this residual ridge contour, it may be U shaped, V shaped, knife edge flat. And coming to the ridge relation, angles classified ridge relation into class 1 normal, class 2 diprognatic, class 3 prognatic. And small amount of inter-ridge distance leads to difficulty in setting teeth and maintaining a proper freeway space. Also known as inter-arch space can be classified with either interspace to accommodate the teeth and excessive inter-arch space and insufficient inter-arch space to accommodate the artificial teeth. Coming to the ridge parallelism, it is divided into class 1. Both ridges parallel to the occlusal plane. Class 2, mandibular ridges divert from the occlusal plane anteriorly. And class 3, either the maxillary or both ridges divert from the occlusal plane. Coming to the bony prominence, and visual examination followed by the manual palpation should be seen, and should check the mid-palatal laphae. If it is needed, any prominence is there and anything relief is needed, and bony spicules and sharp ridge crest and sharp mylohyoid and palatal foramen borders are to be raised and checked, and prominent genial tubercle results from the extreme resorption, bony fragment or fractured root pieces. Come to the maxillary and mandibular tori. It is classified into class 1, 2 and 3. In class 1, absent or minimal in size, it doesn't interfere with the denture. Class 2, moderate size, surgery is not required. And in class 3 is the large tori where surgical contouring and removal of this tori is needed. And if any undercut is there, it causes difficulty in denture removal and insertion, abrasion of the mucosa and pain, and do not aid in retention and may cause some loss of the border seal. So in maxilla and mandibular, if any undercut is there, it should be relieved. Coming to the saliva, both flow rate and viscosity is important for the denture success and lubricates the mucosa and assists the retention. The consistency of the saliva includes thin serous, thick mucus and the fixed. Thin serous is more favorable for the denture retention, and mucus is difficult to work with and tend to displace the denture, and mixed it contains equal quantities of the both serous and the mucus. Coming to the amount, it's normal, is ideal for the denture retention. Excessive, it affects the retention by disrupting the border seal and complicates the impression making and causes problem to patient wearing new dentures. And if it is reduced, reduces retention and increases potential for tissue soreness. And coming to the conclusion, through diagnosis and enables us to make a realistic prognosis. Thus, it is seen that diagnosis and treatment planning helps both dentist and patient understand diagnostic procedure, diagnostic results, treatment plan, and use of the processes continuing the care. Thank you.